Hello fellow pediatricians of the PPS Southern Tagalog Chapter, online CME on Bone and Joint Awareness entitled, My Toes, My Knees, My Shoulder, Masakit? Bone and Joint Awareness Program of the Department of Health in collaboration with the Philippine Pediatric Society is our opportunity to highlight the importance of musculoskeletal health of children. Musculoskeletal pain can cause children and parents great anxiety, and they are often brought initially to us pediatricians. It is therefore important that all of us pediatricians to have the necessary skills to effectively assess patients and do appropriate referral to specialist services. It has been reported that about 6 to 10% of the pediatric ambulatory clinic visits are due to musculoskeletal pain. Most of these visits are due to arthralgia and soft tissue pain, while bone pain was reported in less than 10% of cases. Trauma was the most common etiology. And so this session provides you an approach to the evaluation of a child with musculoskeletal pain. Enumerate as well the different conditions presenting as musculoskeletal pain in children and their approach to management. So how do we assess a child with musculoskeletal pain? First vital step, take a good pediatric history. A good history greatly aids in narrowing the differential diagnosis. And I will mention some important points. For the history of presenting complaint, characterize pain. Take note of the location, its distribution, such as for the joints. Does it affect the small or large joints? Axial or peripheral joints? For bone pain, is it on the area of the epiphysis, diaphysis, or metaphysis? For the muscles, does it affect the proximal or distal muscles? Bear in mind that young children may not be able to verbalize pain, and manifestation may be in the form of refusal to use a limb, assuming a posture of guarding the joints, limping, delay in major motor milestone, or regression of achieved milestone. And take note also of the PQRST of pain, or the provoking factors, quality of pain, radiation, severity of pain, timing, and triggers. Ask for the associated symptoms such as fever, weight loss, rashes. For the past medical history, take note of the following. For patients on chronic corticosteroid therapy, they are at increased risk of developing osteoporosis and fractures. Social history, ask the child's activities or time spent on sports. For family history, ask for rheumatologic diseases, such as juvenile idiopathic arthritis, rheumatoid arthritis, or other autoimmune diseases, such as diabetes mellitus type 1, thyroid diseases. Second step, take a complete physical examination. For the clinical examination of the musculoskeletal system, we do PGALS. This stands for Pediatric Gait, Arms, Legs, and Spine. This is a simple, quick, and easy to perform musculoskeletal screening examination for all children. Following PGALS, the clinician is directed to a more detailed examination of the relevant area or areas using the Pediatric Regional Examination of the Musculoskeletal System, or the PREMS. But with the interest of time, detailed discussion of these two topics won't be done in this session. Bear in mind that the diagnostic test ordered should be dictated by your differentials based on your thorough history and physical examination. So what are the different conditions in children that may present with musculoskeletal pain? In a child presenting with joint pain, typically occurring after activity and able to do these maneuvers without eliciting pain, such as touching the thumb to volar surface of the forearm, Hyperextend the fifth finger of the metacarpophalangeal joint to 90 degrees. Hyperextend elbow to more than 10 degrees. Hyperextend the knees to more than 10 degrees. Able to touch palms to floor with knees extended. Consider benign joint hypermobility syndrome. This condition is applied to children with musculoskeletal pain associated with hypermobility of joints or double jointedness without any associated congenital syndrome or abnormality of the connective tissue. Mild joint effusions may also be observed. Treatment involves reassurance. Supportive footwear is helpful for many. Some children benefit from a post-activity or evening dose of paracetamol or a non-steroidal anti-inflammatory drugs. For severely affected children, formal physical therapy that focuses on re-establishment of normal muscle power and overall reconditioning can be beneficial. In a child complaining of leg pain, particularly in the evening, one can consider growing pain or benign nocturnal limb pains of childhood. In this condition, pain is often located deep in the thigh, shin, and calf or behind the knee. It may be precipitated by exercise or high physical activity. Evenings or nighttime is when the pain occurs, lasting minutes to hours and often interrupting sleep but disappearing by morning. It is never associated with fever, weight loss, night sweats, easy bruising, or a limp. Children with such pain have normal physical examinations. Results of laboratory studies in radiography, if done, are normal. Successful management includes education of the child and family about the benign nature of the problem. Gentle massage is usually effective. Children with frequent attacks, administration of an evening dose of either paracetamol or an NSAID may be preventive. Passive stretching can also be of benefit. If a child presents to you with a monoarticular joint swelling on examination and it is warm, erythematous, severely tender, associated with fever, consider septic arthritis. Septic arthritis is an infection of the joint space in children as a result of hematogenous dissemination of bacteria or directly from surrounding tissues. This is considered a medical emergency. It is monoarticular in majority of cases, affecting joints of the lower extremities such as hips, knees. If hip is affected, the pain may be reported in the groin, thigh, or knee area. It is essential that every child with acute unexplained monoarthritis undergo aspiration of the affected joint immediately. Peripheral WBC count, ESR, and CRP are generally elevated. Blood and joint fluid should be obtained for aerobic and anaerobic cultures. Staphylococcus aureus is the most common cause in all age groups. A number of imaging techniques may be helpful in the evaluation. Plain radiographs are not diagnostic but might be helpful in excluding other disorders and rule out osteomyelitis as well. Computerized tomography and especially magnetic resonance imaging are additional confirmatory techniques. Ultrasound is useful in determining whether fluid is present in the hip joint and is used to guide joint aspiration. The initial choice of empiric antibiotic therapy depends on the age of the child, clinical presentation, and local patterns of antibiotic resistance. The duration of therapy may range from 2 to 4 weeks depending on the response to therapy and the suspected organism. Children with septic arthritis should be managed in collaboration with an orthopedic surgeon. Pediatrician must be alert to the possibility of malignancy in a child presenting with musculoskeletal pain, for it can initially present with joint swelling, bone pains. Further history would show for bone tumors and leukemia, they may present with deep and penetrating bone pain, particularly over the metaphysis of the long bones. and it is usually worse at night. Upon examination, the site of the lesion is tender. Especially in leukemia, they may initially present with arthritis involving the elbows, knees, or ankles. Systemic symptoms such as fever, weight loss are absent in benign tumors while present in malignant forms. In benign musculoskeletal tumors, blood indices, acute phase reactants results may be normal or nonspecific. Especially in leukemia, the acute phase reactants are abnormally high out of proportion to the small number of affected joints, and there is dissociation of the inflammatory indices such as elevated ESR with a normal, low platelet count, or low white blood cell count. In leukemia, blast cells in the peripheral blood may not be present at onset of the musculoskeletal symptoms, in which case bone marrow aspiration and biopsy are indicated. A striking increase in the serum level of alkaline phosphatase and lactic dehydrogenase may be seen. Plain radiograph of the affected area is the best initial diagnostic evaluation in a child complaining of severe bone and joint pains. Note for mass, osteolytic lesions, or soft tissue reactions. Extent of the lesion can be estimated by computerized tomography. Magnetic resonance imaging delineates the soft tissue extent of the early lesions, including bone marrow involvement. Ultrasonography is valuable in assessing extraosseous extension. Once malignancy is highly considered, prompt referral to a pediatric hemo-oncologist is required. In a child presenting with migratory joint swelling and pain, consider acute rheumatic fever. Arthritis occurs in about 70% of ARF cases. Although it is the most common manifestation, it is relatively less specific. It primarily affects the large joints, particularly the knees, ankles, wrists, and elbows. It is migratory in character, rarely lasting more than a week in any one joint. And also look for presence of carditis, Sydenham's chorea, subcutaneous nodules, and erythema marginatum. There are no specific tests available for the definitive diagnosis of ARF. The diagnosis continued to be based on the modified Jones criteria, wherein presence of two major manifestations or one major plus two minor manifestations indicates a high probability of acute rheumatic fever if supported by evidence of preceding group A beta hemolytic streptococcal infection. The latter is a sine qua non for establishing the diagnosis. The initial treatment of ARF should address the eradication of the streptococci as shown in this slide. And subsequent management includes prophylaxis to prevent recurrence of streptococcal infections. Read on further. For the arthritis, aspirin may be given at 50 to 75 mg per kilogram per day in 3 to 4 divided doses. Hallmark of the arthritis in this disease is its exquisite sensitivity to salicylates. A lack of improvement of the arthritis within about 5 days of salicylate therapy should prompt a reconsideration of the correctness of the diagnosis. Major complication is associated exclusively with the degree of cardiac damage. In patients with severe carditis, it may lead to chronic residual valvular disease such as mitral stenosis and may also lead to congestive cardiac failure. In a child presenting with persistent joint swelling beginning less than 16 years of age and persist for at least 6 weeks, consider juvenile idiopathic arthritis. JIA refers to a chronic inflammatory arthritis in children of unknown etiology. This condition may also present with quotidian type of fever, wherein the fever can be as high as 39 degrees centigrade on a twice daily basis. Evanescent or non-fixed erythematous rash, dactylitis or sausage-shaped swelling of the digits, nail changes, enthesitis. Enthesitis is an inflammation of the insertion sites of tendons, ligaments, and fascia, particularly at the insertion sites of the Achilles tendon, plantar fascia, patellar tendon, and quadriceps tendon. Multidisciplinary approach is part of the comprehensive JIA treatment, which involves the pediatric rheumatologist, rehabilitation medicine specialist, occupational and physical therapist, as well as the ophthalmologist. Initial therapy with an NSAID may be started by a patient's primary pediatrician. However, a referral should be made to a pediatric rheumatologist for all patients with JIA to avoid complications such as localized growth disturbances such as micronathia, leg length discrepancy, isolated small digit, and as well as avoid joint contractures. In a child presenting with musculoskeletal pain associated with malar rash, alopecia, discoid rash, oral or nasal ulcers, or multi-organ involvement such as pericarditis or renal involvement, consider systemic lupus erythematosus. SLE is an episodic multisystemic disorder characterized by persistent anti-nuclear antibody seropositivity, widespread inflammation, immune complex deposition in target organs. Based on the latest Systemic Lupus International Collaborating Clinics, or SLIC, classification criteria of 2012, we classify a patient as having SLE if patient satisfies 4 of the criteria listed in the mentioned table, including at least 1 clinical criterion and 1 immunologic criterion. Or, the patient has biopsy-proven nephritis compatible with SLE and with positive anti-nuclear antibody or anti-dsDNA. Read on further. Management uses a multidisciplinary team approach and may involve pediatric rheumatologists, nephrologists, cardiologists, and ophthalmologists. Treatment is based on organ involvement. Sunscreen, calcium, and vitamin D supplements are important as well. Counseling and education about their condition is very important. Medications given to control flares includes non-steroidal anti-inflammatory drugs for minor manifestations such as joint pain and swelling, corticosteroids. Other medications that can be given are hydroxychloroquine, azathioprine, mycophenolate mofetil, cyclophosphamide, rituximab. Pediatrician must promptly recognize when a child has a high likelihood of systemic lupus erythematosus and refer immediately for diagnosis and appropriate intensive therapy. For this summary, for a child with musculoskeletal pain, a good clinical observation and assessment remains central to the management. Different rheumatic and non-rheumatic conditions which may present with musculoskeletal pain were enumerated. Early detection of signs of musculoskeletal condition is crucial for improving management as well as limiting complications. Please answer the questionnaire on the questionnaire page of this site, all for the Filipino child. Thank you.